Hello and welcome to another episode from the TheSynapse eLearning series. With us today we have Dr. Alexander Borg, consultant cardiologist at Mater Dei Hospital, who will be speaking to us about the latest guidelines in the management of hypertension. Dr. Borg, thank you for accepting our invitation.
Thank you.
With us here today. On to our first question. What is your standard definition of hypertension?
Okay, the newest guidelines like to keep things simple. So the definition is based on the office blood pressure. So that is the blood pressure measurement which is taken in a doctor's office, and the cutoff point is 140/90. So anything that's over or equal to 140/90 is considered to be high blood pressure. Of course, there are other techniques for measuring high blood pressure, including home blood pressure monitoring and even ambulatory 24-hour blood pressure monitoring. There are different cutoff points for defining high blood pressure in those situations. So, for instance, for home blood pressure monitoring, we use a cutoff point of more than 135/85. And for ambulatory blood pressure monitoring, we use a cutoff point, a 24-hour average of 130/80.
And in fact, I was going to ask you, what recommendations would you give for measuring the blood pressure of a patient who has recently been found to have a blood pressure of more than 140/90?
Okay.
Any diagnostic pitfalls with regards to this?
Okay. So you come across this patient with a borderline blood pressure or perhaps marginally high. The first thing you have to do is make sure that there is hypertension, so confirm a diagnosis of hypertension. Now, you have to be a bit obsessive in diagnosing hypertension properly. You need time, you need patience, and you need some dedication. So basically, what you need to do, ideally, to confirm blood pressure is to repeat your blood pressure measurement a few minutes after the initial blood pressure. Make sure the patient is relaxed, has been seated for at least 3 to 5 minutes. If the blood pressure is still borderline or high, or you can't really decide, then it makes sense sometimes to place the patient in a quiet room, place an automated blood pressure machine, which will take repeated measurements, say 5 or 6 measurements, and then have a look at the measurements. Another strategy in the GP, in the community setting, is to ask a nurse or a non-medical person to take a blood pressure to avoid the white coat effect. We know about white coat hypertension. It's very common. It affects about 30% of individuals. And it is the presence of high office blood pressures on a background of normal out-of-office blood pressures. Now, that's called white coat hypertension. And white coat hypertension is not in itself a disease. But we're not really sure if the presence of white coat hypertension actually implies a higher risk of cardiovascular disease, but it certainly is much less risky than the presence of true hypertension. As a sideline, white coat hypertension is also common in people with cardiovascular risk factors, so you have to keep in mind that these people may have underlying cardiovascular disease which might need to be addressed. After confirming diagnosis of hypertension, then you move on to taking a history and examining the patient with 2 aims in mind. One of them is to do a complete, comprehensive cardiovascular risk stratification. That is to look for the patient's cardiovascular risk by asking about family history, smoking, checking for sedentary lifestyle, overweight patients, high BMI, checking the urine for albuminuria. So that's the cardiovascular risk stratification. Next, you move on to looking for target organ damage because of the presence of long-standing high blood pressure. So target organ damage can be many subtypes of target organ damage. You can look for left ventricular hypertrophy on the ECG, left ventricular hypertrophy on echocardiography, the presence of albuminuria on spot urine sample testing, renal dysfunction, poor peripheral circulation, a low ankle to brachial pressure index, and a few other tests which people can use, for instance, ultrasound of the carotid arteries to look for intima media thickness. So that's all for part of the spectrum of target organ damage.
And in fact, doctor, when would you make the decision to actually start treatment?
Yes, that's actually a very important question because it's very difficult to pass the message on to patients. Because the definition of hypertension is quite clear, it's fixed, it's a single number which you use, the 140/90, but people are confused because sometimes we start them on tablets, sometimes we don't. That is because the initiation of therapy depends on the underlying risk. So there are some cases where you obviously need to start hypertensive therapy. And these patients are those with very high blood pressure, such as those with grade 2 or grade 3 hypertension, grade 2 being a systolic blood pressure of more than 160, grade 3 hypertension being a systolic blood pressure of more than 180. So those are clearly high-risk patients who will be started on treatment immediately. There are some patients with milder degrees of hypertension, like grade 1 hypertension, that is blood pressure of more than 140 systolic. These are the sort of patients which you try lifestyle intervention on, and if that fails, then you need to start hypertensive therapy in these cases. The other subset of patients at very high risk, even if they have a mild hypertension. So there are those patients which are at very high risk, like diabetics, people with severe chronic kidney disease, and people who already have an established cardiovascular disease. That is, people who've had a myocardial infarction in the past, or a stroke, or peripheral vascular disease. Then somewhere in the middle are those patients who have mild to moderate hypertension, but have a spectrum of risk factors, which in which situation one has to use his judgment. The spectrum of risk factors might be people with borderline fasting blood glucose levels, people with metabolic syndrome, with high triglycerides, with high LDL, people with a family history of premature heart disease, sedentary lifestyle, people with a high waist circumference. So those are the patients where you need to have an informed discussion with the patient and make a joint decision.
Exactly. And that is actually essential in order to ensure compliance, which in the end will affect the response to treatment.
It is very important because you're starting a treatment which will not make the patient feel any better. It's important to get the patient on board and make sure the patient understands why he's taking this therapy.
And what first-line treatment do you suggest in such patients?
Right. All classes of drugs, the conventional classes of drugs, that is amlodipine, beta blocker, ACE inhibitors, angiotensin receptor blockers, and calcium channel blockers are considered equal as first-line drugs. I know there's been a shift in thinking recently, especially after the 2006 American guidelines where beta blockers were relegated to a second or third-line drugs. But we're not really sure if beta blockers, if the modern beta blockers, the third generation beta blockers, like for instance nebivolol, have the same problems that was associated with the previous beta blockers, the first or second generation beta blockers. We know that beta blockers, at least the first and second generations beta blockers, were associated with a higher risk of diabetes, especially if combined with diuretics. Okay, but as I said, we're not quite sure about the third generation beta blockers. For sure, their effect on blood pressure lowering and the reduction of cardiovascular endpoints is probably as good as the other classes of drugs. For sure, there's no compelling reason to believe that they are inferior. So all these drug classes can be started as first-line therapy. Now, one has to make a decision whether to start a single agent or two agents simultaneously. We know that most patients will eventually need two agents, so if blood pressure is quite high and consistently high, one might jump the gun and give two agents simultaneously.
Exactly. How should follow-up then be organized? So we started the patient on a single therapy, and when should you revisit him? When should you see him again to consider whether to up the therapy?
All right. If you just started the patient on therapy, you want to see the patient again in 2 to 4 weeks' time to make sure that there is an effect. Once you established a nice target blood pressure and you have reached your targets, then perhaps you can see the patient every few months.
Exactly.
Okay. If you have a patient in whom you're not really sure what the diagnosis is, someone with borderline blood pressure or someone with white coat hypertension, you really want to repeat measurements, so you might have to get him a bit early, every few weeks to make sure you make the right diagnosis. Once you've made the diagnosis, you've treated the patient with targets, then it is very important not to just abandon the patient, but to review the patient every 1 or 2 years to assess the progression of target organ damage. And in each clinic visit, you can check his ECG for left ventricular hypertrophy, perhaps even check the urine for albuminuria, and do routine blood tests like renal function tests and blood glucose, fasting blood glucose, and cholesterol levels.
I understand that the physician may encounter a number of challenges when he's trying to manage blood pressure for one of his patients who's hypertensive and possibly resistant to treatment. So you started on monotherapy, then you go on to dual therapy, they may interact, he may have problems with compliance, or he may have resistant hypertension which is not actually responding to any therapy. When would you actually advocate specialist referral in these situations?
Right, I think you mentioned most of them. So definitely if you have a patient with resistant hypertension, that is hypertension requires 3 or more drugs to control, it is time to seek specialist attention. Even you have to keep in mind that patients with resistant hypertension might also have secondary forms of hypertension. These forms of hypertension which are caused by something else, like there's an underlying disease which is actually causing hypertension, like for instance a hyperaldosteronism, Cushing syndrome, or coarctation of the aorta, or some rare metabolic diseases, which we all have come across in some of these patients with resistant hypertension. The other situation where you might want a specialist opinion is complicated hypertension, that is hypertension associated with renal failure, hypertension associated with advanced retinopathy. For sure, hypertension in pregnancy is something that requires a specialist opinion. The other situation which actually one might come across is if you're not really sure about the risk stratification of the patient. So now we know there are advanced tests for risk stratification like CT calcium scoring of the coronary arteries, Doppler investigations of the peripheral and carotid arteries, imaging of the brain to look for subclinical infarctions in the brain. These are all things which might help you in the risk stratification, and that's another situation which might need a specialist opinion.
Thank you, doctor. Any take-home messages with regards to the latest guidelines?
The take-home message, I think, is something we all don't do very well, which is being meticulous with diagnosing blood pressure. So making sure that you take the blood pressure in the appropriate circumstances. Make sure the patient is relaxed and use the right size of cuff. Okay,
Very practical.
Yes, something which we sometimes forget because we're in so much of a hurry. We're so busy. And also to make use of out-of-office blood pressure measurements, not just rely on the office blood pressure measurements. We know that out-of-office blood pressure measurements are much more correlated with cardiovascular events. Okay, and encourage the patients to use their home blood pressure monitors. If they buy medically certified machines, they are very good. They are better than office blood pressure measurements. But just be wary of that subset of patients who develop a sort of neurosis when they have their own blood pressure machine. There are some of them out there which can actually be negatively affected with owning a blood pressure machine.
Thank you, doctor, for your time. I hope that this interview has helped to further your knowledge on the latest management and latest guidelines in the management of hypertension. And I invite you to subscribe to the TheSynapse Facebook page and keep updated with our interviews. Thank you.